So by way of introduction, I should say, because our panel is really diverse in terms of our focus, our background. So I'm a clinical health psychologist, and so I work here at the Lurie Cancer Center, and I work all with adult patients. So my slides will be focused really on adults and not on childhood or adolescent. So just to start out with, I think hopefully I'm preaching to the choir here, but I think it's really, really important to discuss sexual health with all of our adult cancer patients, because we know unequivocally from all the research that treating this issue improves quality of life in our patient, it improves patient satisfaction, it improves provider-patient relationships as well. Unfortunately, for a variety of reasons, a lot of which center around our discomfort as providers in addressing this issue, this area is significantly undertreated in our patients. And in fact, this study that I cite here found that only 14% of patients reported even being asked about sexual function by their oncology team. And the reasons for this are multiple. So a number of people think that the physician would just kind of dismiss the issue, or that they would embarrass the nurse or the doctor that they're working with. The thing I hear a lot in patients that I work with is, I didn't think there was anything available. I just assumed that my sexual dysfunction was because of cancer or cancer treatment, and there's just nothing that could be done about this. And then I've also heard a lot of people say, I really should be focused on just making sure my cancer is taken care of, and the sexual health aspect really kind of falls to the back of the line with this. I feel like I shouldn't even be asking about this or worrying about this. And unfortunately, there really aren't any sort of gold standard screenings for how to measure sexual health in an oncology setting. The NCCN guidelines have stipulated for quite some time that sexual health is an important area to evaluate. And so I think that the takeaway message of this for all of us, if there's one thing from my presentation, is you just need to ask the question. I think our patients and family members are much more comfortable talking about this than we would imagine. I remember really well my very first job in oncology out of graduate school was working in a women's oncology clinic. And I remember being immensely uncomfortable bringing up the issue of sexual functioning, thinking, who is going to want to talk about sexual functioning with me, a 28-year-old single white male? Like, who in this clinic is going to want to talk to me about this? But I forced myself to do it, and I can tell you that in the ensuing 20 years since then, I have never, not one time, had a patient be upset with me or offended that I've asked about this. I've definitely had patients say, I don't want to talk about that with you, and that's fine. The goal of asking is simply to let our patients know that if this is a concern for them, we can handle the conversation, right? So there are a number of recommendations for treatment providers, and you'll hear probably a little bit more about these from Dr. Streicher, but it's always important when you bring up this subject, if people do want to talk about this, to talk not only about current sexual functioning, but pre-treatment sexual functioning as well. It's really important to get a good physical and measurement of comorbid medical conditions in addition to cancer that can impact sexual functioning, and then to make use of all of the resources that you have. So psychological, pharmacologic, mechanical sexual aids, all of those kinds of things. There are a number of different acronyms for kind of how to screen for sexual function, but I would argue, this is one of those acronyms, but I would argue that you only need really to pay attention to the first A in this, so you can kind of forget all the rest. As long as we ask about it, that's really the important thing. The other thing when you bring this up with patients is you'll be asked a lot of times, what can I do to help my partner who's having the sexual dysfunction? And I think the first thing is just to normalize that you're going through, in many cases, very aggressive cancer treatment, and this is something that we see very often. Sexual dysfunction oftentimes is a pretty normal part of this. So just to kind of normalize that, encourage open communication among the partners, and then also focus people on the idea that sexual functioning is not the same thing as sexual intercourse, that there are a whole range of sexual activities that people can be involved in, and that can kind of hopefully sort of minimize the performance pressure that a lot of people feel. Also, including sexual aids in the bedroom, for people who may have some physical impairment, to focus them on utilizing sexual positions that are physically the easiest. So this doesn't have to be a circus act. This can just be pretty straightforward. And then also to encourage a brief course of sex therapy with a professional, because there definitely are a lot of tools that are very effective in dealing with sexual dysfunction in our patients. And I'll stop there.
So I'm a gynecologist, of course, so I'm going to be talking about the female side of things. And where's my clicker here? And I think, as Tim mentioned, when we approach these patients, you have to remember that they are not coming into your office having had mind-blowing orgasms and a fabulous sex life before they had cancer, because you have to look at what is the rate of sexual dysfunction in the general population. And I think when people think in terms of sexual dysfunction, they think that's a very small group, because in the media, everyone's having great sex. And they think of it as something that's only in older men and women, and nothing could be further from the truth. Now, this is Jan Schifrin's data out of Harvard, looking at a very large cohort of women starting at age 18. And what we know is that 43% of the general population has some sort of sexual concern, whether it's libido, which is always number one in every population, the ability to become sexually aroused, problems with having painful sex, or problems with the orgasm. And then, of course, as someone hits that menopause age, the numbers go up, not just because of the menopause transition and the lack of estrogen, but because of comorbidities. So it's very important to keep in mind that long before your patient had a cancer diagnosis, there is a very, very reasonable chance that she was already having problems from the get-go. And people are always surprised at these numbers. They're like, really? How can that be? How can there be that many people with sexual dysfunction? Well, sexual response is complicated, and it takes every single organ system. And when I'm teaching medical students, I always say to them, I challenge you to name one medical condition that does not impact on sexual function, because you need an intact neurologic system, you need an intact vascular system, you need muscles, you need bones that function, you need a hormonal system that's intact. So it's really no surprise when you look at the number of conditions and treatments of conditions that impact on sexual function that we see so much difficulty. You also have to remember, biologically, we are put on earth to have sex for one reason and one reason only: to reproduce, right? Sick people aren't supposed to reproduce. Old people aren't supposed to reproduce. So it makes sense that there is not a normal sexual response from a biologic point of view. So this kind of all fits together when you look at the big picture. And then when you look at the cancer consequences, this group is all too aware of the different cancer consequences in terms of body image changes, weight gain, weight loss, scars, loss of hair. I once made the mistake of saying to someone, you know, it's very trendy to have no pubic hair now. And she looked at me like, you know, really? That's not what I'm thinking. I'm thinking that I don't feel like I'm a woman anymore. So we have to keep that in mind. Hormonal changes, which very often are transient, but in many cases are permanent, particularly if they're surgical. Not the cancer, but the treatment, whether it's radiation, whether chemotherapy, surgery, all have an impact on sexuality. A lot of people think it's all about the antidepressants. Yes, those are major culprits, but so is depression. Depression in and of itself is going to increase dramatically the rates of sexual problems. And then, of course, all the obvious things like the family issues, anxiety, and distress that go along with having cancer, in addition to the fact that just because you have cancer doesn't mean that you don't have other problems, which is why 90% of cancer patients experience side effects that are sexual. Does this mean they all care? No, of course not. It is appropriate when someone shows up to their doctor with a cancer diagnosis, what they care about is, are they going to live, not are they going to have an orgasm. But the point is that we know that these issues are there. And it is always striking to me that when a man is diagnosed with prostate cancer, and when he goes for that initial evaluation with his doctor, who talks about his options, whether it's radiation or surgery or whatever it is, and will say, and by the way, there may be sexual side effects. That's all I want anyone to do. Now, no one wants to talk about that initial visit, just to say this is a possibility. And if and when that is ever a concern for you, there is help. There are things that we can do to make that easier. So you just are acknowledging that this person is still a sexual human being, even though that is certainly not at the top of her concern when you are interacting with that patient. So I'd like to present a case. This is an actual case. This is Natalie. I saw her for the first time about a year ago in the Center for Sexual Medicine and Menopause at Northwestern. And she's 37 years old, known BRCA since her mid-20s, had completed her family, and decided to go ahead and have her prophylactic surgery, and went ahead with a laparoscopic total hysterectomy, bilateral salpingo-oophorectomy at the same time that she had her bilateral mastectomy. And completely unexpected at the time of surgery, she was found to have a stage 1 ovarian cancer, so she dodged that bullet because, of course, that was a cure because she was discovered so early. So she was, of course, very happy that they had discovered this cancer early on and went on her way until she presented to me a year later saying, I'm not able to have intercourse. Oh, and by the way, I don't really care. And I'm having all these urinary tract infections. So, basically her story was that she was told by her provider that she should use a silicone-based lubricant, and that worked in the beginning, and then over time, she started having more pain, more dryness, and then she even started to bleed after sex, and then she pretty much gave it up, and about 6 months prior to her presenting to me, she tried one last time, and, barriers to entry, there was no way, intercourse was impossible. And then she'd also was just miserable because it seemed like every time she turned around, she was running to the bathroom, and she'd had 4 urinary tract infections. And quite frankly, she said to me, I don't care. But my husband, our marriage is over. It's on the rocks. I don't know what to do. I have to do something to make this better. So after I spent a lot of time talking to her, I started with a physical exam. And I think, and I don't know how many gynecologists there are in the audience, but gynecologists are kind of too used to going for the gold. And they put the speculum in, with I had you at hello. And it's very important to take a very careful look at the external genitalia, because you're going to learn a lot just from looking. And one of the things that's always quite obvious, a very easy sign that people don't look for in addition to contraction of the introitus, is look at the urethra. It's just poking out there. The urethral funneling is pretty dramatic, and we see this when women have had long-term atrophic changes. And in fact, for anyone who ever still puts in Foley catheters, in the young woman, it's a little bit of a challenge because her urethra's kind of buried, and then as they get older, it's just sitting there, easy to spot. So you look at the urethra, we see that that there is a narrowing of the vagina. You can't tell so much from this picture, but the vaginal mucosal and the vestibule and the introitus is very, very pale. Prior to putting the speculum in, I do a vaginal pH, which is just putting some pH paper in the lateral wall of the vagina, because we know that in women that have vaginal atrophy, that the pH is well above the 4.5 that is normal in a young estrogenized woman. And then, of course, once you put the speculum in, it's very easy to see that there is complete loss of the nice folds, the rugae. There's no more glistening that you would normally see with lubrication. And in this woman's case, there was actual petechiae, which is why she was bleeding after intercourse. I also do a vaginal dilator assessment in which I take progressive dilators and gently put them into her vagina to see what she can accommodate. This particular case, she was able to get the 3rd dilator in, the orange dilator. I then always ask, what size is your husband? When the husband's in the room, they say blue. When the husband's not in the room, they say orange or purple, which is more typical. So I've learned to get rid of the husband when I ask. And Dr. Linda, who you will hear later, taught me the wonderful trick of keeping my dilators in a clear shoe bag so I can hold them up in the shoe bag and display them that way. I also do a very quick pelvic floor evaluation because we know that women who have long-term dyspareunia also have pelvic floor dysfunction from hypertonicity of the pelvic muscles. And even if you don't know the names of the muscles, if you do pelvic exams at all, you can put your finger in and press down on the floor of the vagina, and she will tell you if it hurts. So that was her exam, which was, of course, very, very dramatic. All of this is outlined in a paper which came out last year that Dr. Tesler was the lead author. I think I was the last author. Always good to be, I always tell my kids it's okay to be the last violin in the orchestra as long as you're in the orchestra. And I'm going to let Dr. Lindau tell you about that paper later, but this really goes through the details of the physical exam in the young woman or woman who with a cancer diagnosis. So basically her diagnosis was a severe genital urinary syndrome of menopause, secondary to surgical menopause. We no longer use the term vulvovaginal atrophy in this situation because it is really an acknowledgement that there are estrogen receptors not only in the vagina, the vulva, and the range of the genitals, but also in the bladder and the urethra, which is why she was having the urinary urgency and recurrent infections. And then, of course, she had the secondary high-tone pelvic floor dysfunction. So we talked about a lot of treatment options. And there are many of them out there, including the local vaginal estrogens. There's a ring, there's a tablet, there's cream. We now have vaginal dihydroepiandrosterone, prasterone, which is now FDA approved. We used to have to do it compounded, which is also a vaginal insert. Of course, we have the SERM, espemifene, which is an oral agonist, estrogen agonist, which works very nicely, and then presented carbon dioxide laser of the vulva and the vagina. And after discussing all of these options, of which they are all safe, they were all appropriate, and they all work well, she declined vaginal estrogen on the advice of her manicurist and felt very strongly about that. She really wanted to have some laser treatments, but it wasn't covered by insurance. So she opted to go with DHEA prasterone, which was one suppository nightly. I then also referred her for pelvic floor physical therapy. And then, as Tim said, it is extremely important to get a couples therapist involved, even if they think they don't need it, because believe me, this does have an impact even on the best of relationships. And I don't know if you're familiar with ASEC, but these are basically certified sex therapists who have a familiarity with all of these medical conditions as opposed to just a general talk therapist. So what happened with Natalie? Well, 6 months later, she was actually doing amazingly well. She was highly motivated. She was having pain-free intercourse. Her urinary symptoms had disappeared. She discontinued her pelvic floor physical therapy. And she and her husband were doing very well. They'd seen the therapist. But she decided that she kind of didn't like putting something in her vagina every night, and she switched to the estradiol vaginal ring. So I then saw her again just a short time ago. She had no sexual complaints, and she had switched to a new manicurist who is not quite so opinionated. And that is Natalie. And I just also want to mention that I do have brochures out front about the Northwestern Medicine Center for Sexual Medicine and Menopause. And after we finish the panel, I'm happy to talk to anyone on a one-on-one basis about what we're doing here, because it's kind of exciting. Thank you.
My disclaimer is that I am a pediatric urologist, so urology training with 2 additional years of fellowship training. But really, when I thought about this, I trained for 16 years, and I've been practiced for 10 years, and this is something I feel very passionate about. And I have to say, when I started out, this was something I was very interested in, was sexual health and cancer survivors, and nobody really was thinking about it. But boy, have we had a culture change. And I think the fact that we're talking about it today is amazing. And I am open to your questions during the panel, and I can't bring this up enough, which is echoed here. It's let's talk about it. Bring it up. And I think you have to bring it up when you're seeing a 3-month-old who's going to undergo therapy for pelvic rhabdomyosarcoma, and the dad asks me, will my son be a man? You have to bring it up, when that little guy is going to undergo his orchiectomy for a tumor. You have to bring it up when you see that patient who had a retroperitoneal lymph node dissection as a 10-year-old and now is 17 and can't get it up. So you have to bring it up. And I think the comment about not wanting to bring it up because you don't have anything to offer is a really important myth to address, because I can see as a pediatric urologist, or as a urologist, we have some urologists in the room who are reconstructive urologists or fertility specialists. I know Dr. Brannigan would offer that perspective of we can put a prosthesis in it, we can inject it, we can, there's so much we can do. And I think that's important to let families know. So no matter what the problem is, we can help make it better. But it really does start with talking about it. And I think the other piece is it doesn't have to come from me. The comment about the white man talking is sort of like, the woman talking to the boy, but to the family also. And I think we need to coach parents from the beginning that this is something to anticipate during development, so that it's brought up. And also that it's common among all boys and teens to have that feeling of inadequacy or discomfort. And sometimes the best thing I can do is put them in touch with another teen who's kind of faced that similar challenge, and then they can talk to each other. The other piece is something I learned from the adolescent medicine folks and the adolescent gyne. And as pediatric urologist, I'm a pediatric and adolescent and adult urologist, but sometimes you have to kick the parents out of the room. And you just have to talk one-on-one with that teen and say, gosh, is there something you want to bring up now that your folks are out of the room? And they'll say no. And then you have to push it a little bit. So let's talk about, are you having spontaneous erections in the morning? Do you know what that means? So I do think that piece about feeling comfortable with it comes with bringing it up a lot. And again, I've had a lot of experience talking about it, but if you at least bring it up, Bring it up before treatment, bring it up during treatment, bring it up after treatment, and have this on your radar beyond just the cure and the other toxicities, and knowing that if you have access to multidisciplinary resources, which I know sometimes is not that accessible, something can be done. And it also involves very similar, just a history and a physical. So this was a humbling experience when I was involved in this project, and Lillian is in the audience as the senior author. When we tried to come up with guidelines around sexual health, we looked at the data, and really it was limited and needed, and we had to extrapolate from a lot of the male adult data. And we came up with the thought, take a history and take a physical. Even if you were just to assess Tanner staging, that's the first step. For a lot of the physicians in the room, they're not even comfortable doing the GU exam. And it does involve doing the exam in a compassionate way, and getting that information, and then having the consultation available. So this was in 2012, and we've made some progress since then in terms of the data, but I really encourage all of you who are interested in this field, there's a lot that can be done and needs to be done in terms of additional information for patients and families. So this is a paper, you can look at some of the tables. And this was also looking at a childhood cancer survivor cohort, specifically and compared to their siblings, looking at the erectile function. And we have as urologists these nice questionnaires about incontinence and nice questionnaires about erectile function. And sometimes it's nice to just have that questionnaire and then go from there. And what this study demonstrated was, compared to siblings, cancer survivors were having less sex and they had more erectile function. And what we know in urology is there's a lot of options for treating it. And so just being aware that that is a risk, and being aware that there's a lot that can be done. So on that note, I'm open to questions during the panel. I'm humbled to be on this panel, and I'm really thankful we're talking about it.
Hi, thank you very much. That was very, very interesting. So I have actually a list of 6 questions, but I won't ask them all now. I'll just start with one and then give other people a chance. But I'll ask 2 right now. So, for anybody to answer, and you might have differing opinions. The first is, how can practicing MDs get this training to learn how to address sexual functioning if they don't already have it? And then 2, how, if at all, is the conversation modified to discuss this when you're talking about pediatric and adolescent patients?
Well, I'll start with the training because most people are not trained in this, as you know. I give one lecture to the medical students, and as best as I know, that's pretty much the only lecture that they get. And I think from my point of view, I don't really expect everyone to be really trained in this. What I really want is for people to be aware and refer them to people who are trained in it. And I think that's really important to understand that we can't all be experts in something. And we're lucky in Chicago because we have a number of institutions, University of Chicago, Northwestern, where we do have specialists in this. But what I encourage every single specialist to do is to ask the question. And as has been stated a number of times, nobody wants to ask a question that they don't know the answer to. If someone says, I can't have an orgasm, and you have nothing to say, but I'm sorry, you're not going to ask that question. So that's not the question you should ask. The question that every practitioner should ask is, do you have any sexual concerns, such as, and you have to make a list because they don't know what you mean by sexual concerns, such as loss of libido, the inability to have an orgasm, or are you having painful sex that you would like to talk to an expert about? Just as you would for any other specialty. We all don't know everything, but you're saying, I will get you in the hands of someone. And I think that's what's really important, is to ask the question and then to be aware of who you can refer to. And the other thing I would just want to add is every study has shown that even if you look at the doctors that do ask questions, they only ask them to married heterosexual women. Every woman should be asked. If she doesn't have a partner, she may be self-sexual, she may have a same-sex partner. I always say, even if there's no partner in your life, there's always Bob. We all know who Bob is, right? Bob's your battery-operated boyfriend, and you bet he is charged up and at the ready in households across America. And if she can't use Bob, she's going to be upset. So you don't say to a woman, do you have a vibrator? You say to her, when you use your vibrator, are you having problems? It will open the floodgates up. So That's how you have the conversation.
I mean, I think, you know, what's good for the goose is good for the gander in this one, definitely. I think that there is that added level of being developmentally appropriate at different developmental stages. And so what I know from caring for kids with a lot of anatomic and sexual differences is that you start with supporting the parents and coaching the parents on it, and then you have to have the conversations, you know, when they're old enough, as long as the parents are okay with that, with the parents out of the room. And then you do need to let them know that they're not the only one. Just normalizing it is important. And I think the same goes for the training. I think the biggest thing would be the physical exam is very important in terms of, are they having testicular atrophy? Did they not go through puberty? There's some good guidelines. I was going to talk about that later for referring to a pediatric endocrinologist, because you are obligated to make sure they haven't gone through precocious puberty, or if they, you know, also delayed puberty. So I think the pubertal window is also unique in the boys. I'm sure you could speak the same to the girls.
I also have a question for you
Yeah.
while we're at it, is that
She
what
has
I'm most
6
curious
questions,
about
though, as long as I-
this is a really quick one, is, I mean, obviously you're a urologist, so you're doing an exam of the genitals.
Mm-hmm.
Are general pediatricians, are general pediatric oncologists, are they looking down there?
So I call myself the testis whisperer, and I have like the well penis clinic is what I call it half the time, because a lot of times the pediatricians are referring for the exam. And so I
Yeah,
think
that's kind of
that's
interesting.
okay. You know, that's
As long as they're
okay.
referring,
As
it's the
long
ones
as
who don't
they're
get examined that are
referring.
the problem.
Mhm. Yeah.
Sorry, my name is Lena Nahad. I'm a pediatric endocrinologist, and one thing I was just going to say, even if people are looking, they're not necessarily measuring testicular volumes, which is what you need for early, you know, to see if somebody's in puberty as a male. So, you know, I can't tell you how many notes I read that comment on other things with the GU exam, but they never do the Tanner staging, especially for boys.
My favorite is the GU exam, normal. It's like, what is normal? Yeah.
Well, it's WNL, we never looked.
You're full of good acronyms.
Thank you for having this very important discussion. I wanted to get your opinion on the role of using surveys. I know that there are some very good surveys for sexual dysfunction in men, but in women there seems to be kind of a paucity of information. So how can we implement that in our practice? So for the busy provider, or, you know, because really we should be talking about this, as you said, at diagnosis, during treatment, at the end of treatment, and then serially. So what's an efficient way to use surveys to, or screening surveys?
Well, there are a number of validated surveys for, of course, research purposes, such as the FSFI, and there are some shorter surveys as well. I've made my own surveys, which are not validated. They're not for research purposes. It's just a good way to introduce the topic, because, as you correctly stated, a lot of patients will be much more comfortable filling out a survey. I'm amazed, actually, what people will write on their surveys. And it is easier to do that than to perhaps start the conversation. And also, I also want to just talk about the role of the advanced practice nurse, because especially in the oncology world and some of the other specialists, they're so focused, there's so little time that they don't have the time, and very often it is an advanced practice nurse that is absolutely gold in terms of starting the conversation and having the conversation. And we can't ignore the fact that while some of the best sexual medicine experts in the country are men, it doesn't stop the fact that women are not comfortable talking to them, but they will fill out a survey. And I'd be happy to share some surveys with you after, some links.
And you know, the thing I would caution, because you said, oh, there are good ones in urology, not really. I mean, we are good at, you know, erectile function, but even then, when we've looked at the reading level, you know, it's really above the 8th grade reading level, and when we've also looked at it across culture, it's probably not the best, but you use what you have.
Hi, is this on? Okay. I want to thank you guys for sharing this today, because I know how important it is to talk about our sexual health. I don't think that's talked about enough amongst a lot of groups of people. So I was just wondering, from a psychosocial standpoint, is there ever a time as healthcare providers where you are not concerned about a patient's lack of interest in sex?
I would say no, never. There's never a time when I'm not concerned about sex. Even people that are being referred to hospice, or you know, are really not being treated curatively anymore, but palliatively. I think it's always important to ask.
Okay.
Well, but important to ask, and I think, I mean, my point of view from your question is are there times when I say to someone, do you have sexual concerns, or do you have difficulties, blah, blah, blah. And if they say no, my next question is this a problem for you? And because a lot of times there are other priorities in life, and it doesn't have to always be about sex. And I think I'm only concerned if someone says that we use the word distressful, but if they're frustrated, if they're upset, if it's impacting on their relationship. But I think it is okay. We go through sex cycles in life. And there are times when this is a high priority, and there are times when it's a low priority. And I think it is always something that we should bring up. But I think it is acceptable for someone to say, no, I'm okay right now. This isn't really a concern. And then I follow that up with, okay, this is fluid. One day it might be concerned. I know you can talk to me.
Okay.
Yeah, I can't echo that enough. I think as long as you open the door and say, okay, if that's not a problem now, maybe in the future. I do start talking about contraception, though, even before they want to talk about it, because I think they need to hear about it. I know that the endocrinologists in the audience can talk about this as well. Talking about the fact that just because they've had chemotherapy doesn't mean they can go out there and have unprotected sex. They could still sire, I like the word sire a pregnancy. They can still get STDs. And so just like any other teen should be talking about this before it becomes an issue, so they're prepared.
I think also it's important for us to come back to this and not just ask the question once. And I think a really good way to kind of put that in your head is at any sort of transitional point in treatment, I think is a really good time to ask about that. So if they're going from chemotherapy to radiation, it's a good time to just revisit that really quickly. Or if they're going from, active curative treatment to palliative care, it's a good time to ask. So anytime there's kind of a major transition in treatment, I think it's a good time to just kind of have that in your head to revisit.
And I want to echo that, and also just say at the Center for Sexual Medicine here at Northwestern, we track what brings people to, are they referred by someone, are they referred by a center? And I'm kind of just absolutely floored by the idea that 90% of the patients are self-referred. That means their doctors are not directing them there, and we have to change that. Bring it up. They will, like you said, no one's ever upset that you've brought it up, ever, ever. They're grateful.
And I think the nice thing is when you start referring, you develop a relationship with that referral provider, and so you actually learn in that exchange, and so the next time you bring it up, you actually have more tools. And so even just developing that referral relationship is key.
Hi, I have a question about privacy and documentation in adolescents. And so the first thing, if I bring it up to an adolescent, is my parent going to find out? Well, in our hospital, yes. If they request the medical record and I document it, then yeah, they're going to find out. So it's always a quandary of, am I going to get an honest answer? And how can I make them feel comfortable sharing?
It's not just with kids. I see patients who are employees at Northwestern, and they don't want anyone to click onto their medical record and see that they were seeing me. I was able to get the same privacy thing on my notes as a psychiatrist. I had to fight for it, but all of my notes are private.
Okay, in our hospital, that's not true. Even not the psychiatry notes aren't private.
Oh, my. Ooh, well, that's tough.
Right.
Because at our hospital, we've moved to MyChart, and so the parents have access to the chart up until age 12, and then they don't have access to the chart. And then at age 18, the patient themselves can sign up for MyChart.
Do they have access if they put a request through medical records? Because that's where our confusion comes in, because if they put a request in through medical records, I mean, not many people are going to do that, but if they ask me, then I'm going to have to say, and then it's a problem. It's a big problem.
Yeah, I think then sometimes you have to be off the record. I would have those conversations with the parent out of the room, talking directly
Definitely.
to the child. And then sometimes you have to ask him, are you comfortable with me bringing this up to your parents when they come back? And then there are reproductive rights. I know this is true for girls. I don't know if you want to talk a little bit about that.
In Illinois,
So-
the law is that you are an emancipated minor when it comes to matters such as pregnancy and contraception. And it's always interesting to me that if you are pregnant, that you can make your own medical decisions, but the minute you deliver, you cannot. But you can make decisions for your baby, just saying. But yeah, but you are protected, which is why someone could walk into Planned Parenthood at 15, thank the Lord, and get contraception.
Yeah.
Donate Planned Parenthood.
And I'm just going to add, I'm just going to add on that. I think building trust with the patient and the family is key, especially around these topics. And sometimes this can be a vehicle for building that trust, or the opposite. I know that, you also have to be culturally sensitive. There are patients where I can't shake their hand. or the mom has to stay covered up, if there's a man in the room. And so I think we need to be culturally sensitive to that and let them know, you do have access to these records if you asked for it, but it's probably best that we maintain that patient relationship. It's tough. That's a tough one, especially
Thanks.
at your institution.
Hi, Leslie P. again. I just wanted to put a plug in for using your electronic medical record. At a previous institution at the University of Kentucky, we used our EMR to screen for sexual dysfunction, and so the nurses during their risk assessment would ask these questions, and then it would trigger a consult to the licensed therapist. And so there were lots of questions that would trigger the consult, but that was one of it. So I would just encourage individuals to consider using your EMR to make things more practically useful for you.
And I know there's some survivorship folks in the audience who've worked with COG and the Children's Oncology Group and the long-term follow-up guidelines. I think there's still some barriers to merging that with the EMR, but there are some nice guidelines, at least guidelines for now.
So to follow up with that, because I'm at University of Kentucky, Allison Rasper, and I'm an adult male reconstructive urologist and specialize in survivorship and sexual health. I know this is more of a statement rather than a question for the panel, but I know that we all understand that it's a multifactorial for the patient, but I would also suggest that it's a couple's health. And whatever the definition of that couple is, I'm not trying to define the couple, but I do think it is an important conversation. I think our training puts us in silos, so I deal with male. I just addressed that I deal with males. But I think it's important that we address whatever the definition of that couple is so that we can assess this situation to help the couple.
I'm glad you went to the mic because you knew I was going to call on you.
So, Kristen, I'm reminded of a panel you ran like this a couple of years ago with some of our patients where erectile dysfunction came up. Mm-hmm. And it was a group of, I think, Matt Zachary from Stupid Cancer and Johnny Immerman, and it was the patient's perspective. And I just wonder if in the room, the patient's perspective, not to put you on the spot, Matt, but this really was something that wasn't talked about when you were a patient, and this the sexuality issue was a prime concern for young cancer patients, and there just wasn't a process. And so I want to make sure that we come back to what the patient needs are and then maybe deliberate on what the process should look like so that the patients are getting into the custody of people who can aid, and in that fluid manner, not just at one time, but in multiple times. And so what might that process actually be like? Would it be to tell the patient, come back in 2 years, so that they know that there's going to be some changes over time that you would be willing to talk about? Or what should that look like, I guess, is the question I was asking.
Well, I think part of the problem is that there's a big difference between being affiliated with a major medical academic center and being in the middle of nowhere. And so certainly if you're at a major academic center, the process can be as simple as handing someone a brochure that they can keep in there. People will keep things. I think it's important. We're so paperless sometimes that we forget that people like to keep stuff. And I'm a believer in brochures. You just hand the patient a brochure and say, here's where you go if you have problems. It is much more difficult if you are out where you don't have those kinds of resources, but I would encourage everyone, there are certain websites where you can certainly find therapists. ASECT is the organization that I mentioned that has wonderful, wonderful certified sex therapists. ISWISH is an organization, the International Society for the Study of Women's Sexual Health. You can find practitioners that are good at this. NAMS, which is a menopause society, but because so many of the problems that people are dealing with are actually as a result of an early menopause from their cancer, or they're looking for alternative treatment. So there are certainly a number of professional societies that will lead you to people that you may not know existed in your area. And then give it to the patient on a piece of paper, because they will put it away. They'll find it, that shriveled up, torn piece of paper a year or two later.
The only other thing I would say is I think also patient support groups for a given type of cancer can be really helpful. If any of you have ever been to a prostate cancer support group, for instance, I have been consistently amazed at what the people in those groups are comfortable talking about erectile dysfunction, all kinds of medical problems related to prostate cancer and prostate cancer treatment. And so I think in doing that, you can affiliate people with other people who've been through that problem, and oftentimes they can actually be kind of our best referral sources to resources in the community that they've found helpful.
I just want to comment. So I understood the question as what should the process be? And I think this is a challenge for every institution, but I think if we, at the time of diagnosis, reinforce that this is a lifelong process and that each developmental stage, I'm talking, from a pediatric standpoint, will have its challenges. So for example, some of my patients, I'll say, okay, I'll see you at age 1, then I want to see you after potty training, then I want to see you at age 10 when you start smelling bad, and then I want to see you regularly. And so, and that might not be your urologist, actually, it might be your pediatric endocrinologist, and I think that speaks to find the resources you have and build that team of networks, and definitely have them come back. Because someone said, when do you worry if it's not an issue? Well, if it's not an issue now, it's going to be an issue at some point, and so at least they have that open invitation. I also think that handout is key. One of the things I give is a grab your gonads handout when there's, 2.
Grab your gonads?
Yeah, I love this for
love that.
self-testicular exams, because we know survivors are at risk for second malignancies, and just like any teenager should be checking down there. So,
Is that for the girls too, or just the boys?
well, they can't grab. Well, they might be able to
Oh,
grab
I'm
theirs.
just
There's a
saying.
lot of different girls' anatomy, and so, but I think that's a really important piece. And how to build that into the EMR. How do we trigger that 2-year follow-up appointment? Is really a challenge, and patients move.
But the follow-up, and then Tim, you can answer this one. How often do people come to the survivorship clinics? What is, because I know that the last time I asked was a couple of years ago, and it's pretty low.
Yeah, and it's still relatively low. So cancer survivorship as a concept is still relatively new. And so people are doing survivorship care clinic visits in a multitude of different ways. Sometimes it's the actual oncology team that's doing the survivorship care visit. Other times, like places like here, we have an actual separate survivorship clinic where people can be referred for a one-time visit, basically, where they go through their entire treatment history and what they need to look for in the future, what appointments they need, how often they need to get scanned, and so forth. And then they have the option of coming back, but at least in most places you get one survivorship care visit, and it's not really revisited, unfortunately.
And there are members in the audience who might have some, I like the comment that this is a statement, so if anyone wants to share their experience with regards to any of these, both survivorship or urologic, please, join the panel, come to the mic.
Actually, I had a comment. My name is Mili Thakur. I'm a reproductive endocrinologist, infertility specialist, and medical geneticist. And you actually pointed it out. You shouldn't say normal or abnormal for something. You should say there are differences. If they look different, if they have an organ that's different, or by the virtue of the treatment that they went through, it's a very individualized thing. There is nobody as unique as that person standing in front of you. When 2 of them come together as a couple, there's nothing in the whole entire universe that is that person. Their genetics, their life up till that point. So we shouldn't put our perspectives into saying, oh, you are normal or not. We are not there to judge. We are there to understand their situation and move forward. I think that's a thing that we learned in genetics. It's so unique.
I removed the word normal from my vocabulary, because when people say, well, will my son look normal or be normal, I say, what is normal? I use the word typical or optimal, and that's a very genetics thing that I learned, the differences. And I think that almost normalizes it, like what you said.
I use the word healthy. When I do an exam and I'm looking at something, I say,
Healthy.
this looks healthy.
Yeah, healthy is another good word.
We'll go James.
Hi, I'm James Wren. I'm one of the infertility fellows here for male infertility with Dr. Brannigan. So I did my training in urology, and just echoing to your point, we've sort of gone through a paradigm shift in urology with regard to a certain number of malignancies. Testes cancer back in the 70s, you had a 70% chance of mortality. In predominantly young males, and in prostate cancer as well, in the 60s, 70s, you still had a very high mortality rate. So we're now dealing in male infertility with predominantly senior urologists who had gone through a time period where there was significant mortality risks. And now, in terms of testes cancer, that's reduced to less than 3% chance of mortality, which is predominantly based on cisplatin-based chemotherapy, RPLNDs. And prostate cancer mortality rate has significantly declined. So it's a complex issue which we're dealing with, where education, even amongst urologists, even amongst some of the senior ones, and accruing knowledge and passing that on to patients is still somewhat of an issue, having come from Indiana, which is very testes cancer strong, where cisplatin-based chemotherapy and RPLNDs were essentially revolutionized. Trying to get these guys thinking on an infertility and erectile dysfunction basis was incredibly challenging. And to the point where they still weren't doing semen analysis prior to orchiectomies. They started to change with time toward the end of my residency with sort of education. But even now, it's still an issue just with testes cancer. And then you move to prostate cancer. And you look at a lot of patients, even in the literature, where erectile dysfunction, even now people still report that there's only an 80% chance of, or 80% chance of maintaining erectile dysfunction. It's much lower than that. And so there has to be an accurate assessment by the urologist and the physicians and expectations of the patient of what they'll experience. One other thing which was pointed out as well is that the lack of patient options and understanding of what's available. There's been a paradigm shift as well when you talk about prostate cancer and what options are available. We now know that rehab within the first year is particularly important when we use PDE5 inhibitors, whether it's Viagra, Levitra, Cialis. These are particularly important in order to prevent apoptosis and hypoxia within the cavernosal smooth muscles. A lot of these patients don't know that they still have options. Even if they fail, then you still have intraurethral muse and intracavernosal injections and IPPs. And this is part of the problem, is if you don't educate them from the word go, even if it's patients who are being treated predominantly by oncologists for castrate-resistant disease or undergoing adjuvant therapy with radiation, you can still optimize their function. But from a urology perspective, from an oncologist, it's something that it has to be passed on. And the importance of brochures is extremely important. These patients are often very nervous about what they're coming in to talk about. But from a urology perspective, there's been a huge paradigm shift in the focus of curing patients that we've now accomplished to optimizing overall quality of life care. So.
And to add on that, we looked at a cohort of adolescent young adult health outcomes perspectives. This was an NCI study, and we saw that the greatest predictor of bringing up reproductive health issues was having a medical oncologist, not the surgical specialist on the team. So I think you are the front line. And I think that urology, just like every other specialty, is shifting in terms of its focus because the patients are telling us what's important. That patient perspective, if you listen, is so powerful. And I think that's why we're seeing that shift. It's got to be more than cure.
Hi, my name is Jenny. I'm a master's student here at Northwestern. First of all, thank you so much for bringing up these topics. I can't even imagine how important this must be for your patients. So one thing that I'm really interested in is the question of access. And hearing you guys discuss this, it makes me think, what might care look like for a rural population or a rural patient, or a patient living in a rural community, versus someone who lives in an urban area who might have a specialist who is a 15-minute drive. And I know some resources were mentioned, websites, but I'm curious, for a pediatric patient or a patient who's older, what resources might a provider be able to hand to that patient to deal with that, in between actual clinical contact?
Well, I'm going to do the 10-second plug for my book, which you can get on Amazon Kindle for $1.99. We just brought down the price. It's Sex RX, Hormones, Health, and Your Best Sex Ever, and that's what my book is. It was intended for people who don't have access to a provider, and it essentially goes through in excruciating detail every single thing a woman needs to know in terms of the challenges that she might have, not just from cancer. I have a specific chapter on cancer, and I specifically talk about chemotherapy, radiation, but I really talk about every single medical condition because there isn't the resources out there.
I don't have a book to plug, but I am in Seattle, and actually, you go right outside of Seattle, and it's like another world, you know, this bubble. And we serve the WWAMI region, and so I take care of patients in areas of Alaska I've never heard of. In Idaho, they don't even have running water. They use well water, or one of the checks on my review of systems is, do you use a wood-burning stove? And so what I've learned from that is, again, how important it is to partner with the primary care provider. Gosh, those folks are key. And also having clear follow-up guidelines. So come back for X, Y, and Z. You know, when we looked at access issues, you know, some of it is, you know, rural versus urban, but the biggest issue is education and insurance. And a lot of our AYAs don't complete college because the treatment disrupted their education, and lose their insurance because they're in that middle ground. They're no longer under their parents. And I think that's a really big challenge. And that's where the advocacy comes in. I'm not an expert in that, but that's key.
And I think it is, a lot of places, it's really bleak. There aren't specialists that can treat this, but the one thing I will say is, don't underestimate your patient's ability to be resourceful and to travel. Before I came here, I was in New Orleans and lived through Hurricane Katrina when the entire medical community bailed. So there was really nothing to refer people to. But I had a number of patients that, even though they were uninsured or underinsured, found the resources somehow to actually travel to Birmingham, to Atlanta, to you know, the closest big cities to New Orleans to actually get this care. So I think bibliotherapy oftentimes is kind of the best you can do locally, but don't underestimate people's ability to travel.
And we can do a lot in one visit, I'm just saying.
And the other thing,
sometimes that's all it takes.
Yeah, we had a hard time finding a sex therapist that was comfortable with our patients that had some differences, but also with this patient population. And so we ended up partnering with a sex therapist who would do some of the consultation via Skype, telemedicine.
Yep.
I mean, you know, we do, patients are resourceful, but so are we as providers. And so I think there are opportunities out there, and we just have to find those resources and make them available.
And I'll plug the navigator model in here, because I can say, as the navigator here, I have patients that come visit me from all over the country, whether it's a very urbanized area that doesn't have this or a rural area. And what they can do after calling is have me set up multiple visits in one day. So they're making one large trip in, but they're getting everything they need to get hit on in one day. And then I can help them through all those extra things that a provider by himself or herself isn't able to do. So I think for a lot of larger medical centers, you should have a patient navigator.
Absolutely.
Yes.
That is so true.
We've got just a couple more minutes.
Hi, my name is Abby Riazi. I'm a physician assistant in pediatric urology at Cincinnati Children's Hospital. Thank you for this excellent discussion. My question pertains to, obviously, the pediatric and adolescent population, for those on the panel or in the audience. At Cincinnati Children's, we obviously have a very strong Oncofertility program, and I do a lot of the male fertility consults pre-treatment. But I don't typically talk to them about erectile dysfunction or sexuality during that initial consult. They have just been diagnosed, they have a lot of information, and we're trying to get more of an urgent decision on fertility preservation. So for those that are seeing the pediatric male population, do you do your sexuality conversation at the time of a fertility consult? Do you typically have them come back at Survivor clinic and see them then? Or do you just kind of say that you will address this at the different phases of life? Just curious to see what other institutions are doing.
So I can say here, we actually do talk about erectile dysfunction, and we do because we've had so many young men who cannot get an erection and are unable to bank because of that. So I have found that for us, it's been very important to normalize that off the bat and say, hey, you've got this big cancer. We're gonna try to bank, but if you're trying for 10, 15 minutes and it's not working, it's okay. And what that means is that, we're going to try all these different methodologies. Tim has actually seen some of our patients to do some counseling in between sessions so that we can bank. And I think it's been really important for a lot of our young men to hear that, okay, there's not something horribly wrong with me. And I think that's been nice for us, and we kind of learned that by trial and error, having a couple kids coming out crying because they weren't able. So I am mostly just seeing the post-pubertal, and then Barb, who's not here, sees most of the yeah.
For the prepubertal ones, it's nice. The fertility preservation is a nice segue to bring it up, and it's on the parents' minds. The mom is asking about the grandkids, and the dad's thinking, if there's a dad, or the other mom, or the other dad, is thinking about the erections and the manhood. And so you're just bringing up the elephant in the room, and just letting them know that's something to think about down the road. But it is an opportunity, and you don't want to overwhelm them either, but it's an opportunity to bring it up.
Stacy. Yeah, so if you couldn't hear Stacy's comment, it was really using that also as a great segue to talk about contraception too, which I think especially in the pediatric world, we don't always do a great job of addressing that. Last question.
Hi, I'm Melissa Thompson, and I am a patient. I'm an Oncofertility patient. I'm a patient at Sloan Kettering, and I'm very fortunate that I was educated after diagnosis. I was diagnosed when my baby was 5 weeks old. So I was educated, I was referred out, and Sloan Kettering does a great job at making patients aware of their options. Where I've been troubled is once I was referred to the RE side. There's an issue that was plaguing me when I walked in during the question about the couple, and I think I interpreted that differently. When I went to the RE's office, I felt like I was treated like an IVF patient, where I was the couple, and I was with a partner. We were not married. And in retrospect, I feel like I was the patient, he wasn't. And I was treated, all the forms are set up, so the couple is the patient. It was, the forms are, consents are fitting a square, the round peg, square hole, and the treatment and education as well. So unfortunately, that actually cost me my fertility preservation, because I ended up with a decision that I wouldn't have made if I was the patient on my own. Do you think there's a model of care for the oncofertility patient that could be proliferated through on the RE side to account for the nuances of the cancer patient?
Yeah, so I can definitely address that. At Northwestern, it's a big deal to us. When we have patients who are partnered, I especially want to make sure that they know all of their options, and even options that don't include their partners. So every single one of our patients that banks sees our clinical psychologist specifically to have that discussion about banking eggs versus banking embryos, or maybe doing a combination of the both. Because what we're finding is in couples who are even married, cancer's hard and it destroys relationships sometimes. Some of these other diseases are destroying relationships, and we want to make sure that at the onset of having these discussions about banking, we're discussing about you as the patient, what is your long-term goal, and understanding that their partner needs to kind of hear this as well. And so I would say once we've started implementing that model and discussing that more, banking eggs versus embryos versus a combination of the both with our psychologists, the vast majority of even our married couples are splitting, banking both eggs and embryos. And I think that you'll start to see that expand as we learn more about the oncofertility field, and we can share more of our best practices and methods and models like this, for sure.
Thank you so much for bringing that up. Because I think what it underscores is you are not the same patient walking into that office. And that is something we've learned with boys. It's not the same thing to go and offer your seminal fluid analysis. You can't have Playboy, you get Blue Lagoon, and you shouldn't try for 12 months, maybe 6 months is it. And I think that you bring up something that I don't know what the answer is, but maybe those of us in the room can work on, really tailoring to those unique needs. That's heartbreaking.
I was thinking, if we walked in and if he was the cancer patient, would they ever say to me, you, the healthy person, we're going to go through a cycle, so then we're going to fertilize your eggs? That would never come up.
Nope.
But women are put in the other position.